Hello, everyone. Welcome. Thank you for joining us to Heart and Stroke's Women's Heart and Brain Health Research Webinar Series, Research Impacts and Opportunities, number 1. We have a number of audio options for you to use today to join us. You can listen with your computer speakers, in which case I hope that you would turn them up full volume, or you can listen via phone. The GoToWebinar platform will generate a phone number for you, and you can use that to dial in. Everyone will be muted. In the event that for whatever reason you are not muted, I ask that you please mute yourself to improve the audio quality for everyone listening. Questions will be taken through the question box in the GoToWebinar platform, so send questions in as they occur to you. Our moderator will field those questions and send them to our presenters at the end of all of their presentations. The webinar will be archived and uploaded to the Heart and Stroke YouTube channel following the session, and a link to this recording will be sent out to everyone. Likewise, an evaluation form will be sent out to everybody following the session, and I ask that you please take a bit of time, it's very brief, to fill out the evaluation. It'll help inform future sessions like this. We're so pleased that you joined us today, but I hope that you keep the conversation going and follow us on Twitter at Heart and Stroke, and follow our hashtags, hashtag Heart and Stroke Science and hashtag Beat Inequity. Finally, if you haven't already registered for the following webinar opportunities coming up in the next couple of weeks, April 20th and 21st will be the second and third installments of this series, showcasing some of the early progress and successes and reflections of the researchers who've been funded through this initiative. And then finally, on April 29th, a look to the future, building on the progress that has been made related to sex and gender and adding further nuance with an intersectional lens as we further evolve this work in heart and brain health for all. Now, before moving into the formal program, I want to pause and acknowledge the land from which I'm joining you today. Pardon me. From Ottawa, I am on the traditional unceded lands of the Algonquin and Anishinaabeg peoples. At this time where many of us find ourselves being told to stay in place or rest in place, I encourage you to consider the history of the place where you find yourselves and the community that you are currently surrounded by geographically and socially. We're joined here in this webinar because of a shared commitment to health equity. And I encourage you to think about what that means to you both personally and professionally as you listen to our speakers today. And health equity really is the impetus for this whole initiative. Starting in 2016, Heart and Stroke received 5 years of funding from Health Canada to advance research related to sex and gender and to change policy and practice, but also to accelerate the adoption of sex and gender-based analysis and reporting by research funders and to build capacity for investigators who are in the field. This has been accomplished by knowledge translation activities like this, but also through funding research directly. We were able to leverage that initial $5 million investment to secure an additional $3.5 million through partner funds and donor funds, and we've been able to fund 26 projects across the country. This initiative has really catalyzed a change, a fundamental change in the way that Heart and Stroke has funded research. Even last year with the economic downturn because of COVID, $17 million approximately of research was funded, and all research competitions now funded by Heart and Stroke include sex and gender as part of our funding guidelines. The objectives for this webinar series are to share some of the research progress from the first round of funding from the Women's Heart and Brain Health Research Initiative, but as I said, also to look forward to the opportunities related to women's heart and brain health in the future. And we are in the very capable hands of Ms. Ismalia de Sousa, who will be moderating for us today. Ismalia is a PhD student in the School of Nursing at the University of British Columbia under the supervision of Professor Sally Thorne, Dr. Sandra Locke, and Dr. Talia Field. She is a doctoral research student looking at interlocking of the stroke care, equity, and gender, and other intersectional factors. She's got 10 years of experience in stroke care in the UK as a registered nurse and later as a clinical nurse specialist in stroke. She's held research roles in the UK that influenced healthcare policy, changed practice, and advanced the field of stroke nursing. And finally, she's a recipient of the Graduate and Fellowship Research Award in Women's Health from the Women's Health Research Institute and the Women's Health Foundation. And now I will turn it over to Ismalia.
Thank you so much, Kirsten, and good morning, everyone. It's my absolute pleasure to be moderating this session today. I'm joining this space from the unceded, ancestral, and occupied territory of the Musqueam, Squamish, and Tsleil-Waututh nations, also known as Vancouver. In today's webinar, we have some remarkable scholars, and as a trainee, it's an absolute privilege to be surrounded by them. So without further ado, I would like to welcome and introduce them in the order in which they will be speaking and presenting today. Dr. Susanna Mack is an associate professor in the Department of Medicine's Division of Cardiology at the University of Toronto. As a clinical cardiologist, she is a heart failure specialist at the Anna Prosserman Heart Function Clinic, which is the longest serving heart failure clinic in Toronto. Dr. Mack has recently launched a clinical research program to precisely phenotype the cardiovascular physiological contributions of dyspnea, known as the breathlessness revealed using exercise to assess the hemodynamic response program. And this program aims to provide state-of-the-art diagnostics for syndromes of breathlessness relating to aging, heart failure with preserved ejection fraction, and pulmonary hypertension. Our next speaker is Dr. Michel Shani. Dr. Shani is an attending neurologist at the Ottawa Hospital, an assistant professor at University of Ottawa, and an associate scientist at the Ottawa Hospital Research Institute. His research program contains 3 pillars linked by an interest in physician decision-making. So acute stroke diagnosis and treatment, clinical trial, ethics and epistemology, and end-of-life care. He is co-chair of the Canadian Stroke Best Practice Recommendations on Hyperacute and Pre-Hospital Stroke Care, ethics chair of the Canadian Stroke Consortium, and both fellowship and scientific director of the Ottawa Stroke Program. Dr. Margie Davenport will follow. Dr. Davenport is an associate professor in the Faculty of Kinesiology, Sport and Recreation. She received her PhD in 2010 in integrative exercise physiology from the University of Western Ontario and conducted a 2-year postdoctoral fellowship at University of Calgary. A research program examines the metabolic and cardiovascular adaptations associated with normal and complicated pregnancies. A primary interest is in the benefits of exercise prior to, during, and following pregnancy. And lastly, but not least, our Dr. Husam Abdel-Qadir is a cardiologist at Women's College Hospital and University Health Network, and a scientist at Women's College Research Institute, the Ted Rogers Centers for Health Research, and the Institute of Clinical Evaluative Sciences. He graduated from the University of Toronto's Medical School with the Silver Medal in 2007, followed by residencies in internal medicine and cardiology, and a PhD in clinical epidemiology and healthcare research at the Institute for Health Policy, Management and Evaluation. His research expertise is in cardiac care of breast cancer survivors. So welcome all again, and I would like to hand it over to our first speaker, Dr. Mack, to begin the presentations.
Okay, I'm really excited to be here. I'm just going to wait for Kristen to get my slides up. But I do want to thank the Heart and Stroke for the opportunity to participate, and really grateful to be here with all of you and my guest or my co-panelists today. Very excited to hear about your work. There we go. Should I just go? Kristen, will you just let me know when I should go ahead? Okay. So if you go back just to the title slide, my research program has always been focused on heart function and the heart as a muscular pump, right? My further interest is what happens as we all grow older and how we all experience disease as men and women. Next slide. The actual grant that was funded has the title, The Role of Exercise Hemodynamic Testing to Improve Pulmonary Hypertension Diagnosis in Older Adults, and the grant is currently in year 3. So pulmonary hypertension is a cardiovascular condition with high morbidity and mortality, and it affects women 2 to 3-fold more frequently than it affects men. The onset is insidious, and the main symptom is breathlessness, and diagnosis is often delayed. The gold standard for diagnosis is resting right heart catheterization, in which we directly measure high pressures in the pulmonary artery. And these hemodynamic pressures can also be high in other conditions, like heart failure with preserved ejection fraction, another condition which causes breathlessness, and another condition that demonstrates a clear predilection for women. So it's quite important to distinguish these two disease states because the treatment can be quite different. And the study is a prospective investigation to evaluate whether adding exercise, like a stress test, to arresting right heart catheterization can make the cause of pulmonary hypertension clearer, and whether we can better predict the response to pulmonary hypertension therapy. So next slide. So this is what my laboratory actually looks like and where we do this research. So it's a catheterization laboratory, and it was actually purpose-built for research. So this top picture shows me inserting a catheter from the vein in the arm that then is placed in the pulmonary artery through the chambers of the heart. And what you can see is we can record pressure signals. So the upper right panel are signals from the pulmonary artery. And if this pressure is high, the patient has pulmonary hypertension. The lower pressure is known as a wedge pressure, and just as a brief description, it's a pressure of the, or it's an index of the filling pressure of the heart, and this tends to be high in patients who have heart failure with preserved ejection fraction. Next slide. And this grant is, so you can see on the previous slide that we actually can do these kinds of measurements and instrumentation while patients are exercising. So this particular grant is part of my overall research program to understand exercise intolerance in older men and women. And the tagline for my laboratory is that the ability to exert, exercise, or be active is fundamental to human health and well-being. So next slide. So as important as exercise is, you will likely not be surprised to learn that really the majority of patients do not meet our guideline recommendations for weekly exercise due to a variety of reasons that range from physical to cognitive to social. And as a result, people do not access the benefits of exercise. Next slide. So a very important experience that prevents many people from exercising is that of breathlessness. And it's been observed that up to 30% of apparently healthy men, and particularly women, experience enough breathlessness that limits their instrumental activities of daily living. So these are activities that include socialization, shopping, meal preparation, maintenance of one's residence, for example. Next slide. So the question that interests my laboratory is simply what happens to the overall function of the heart pump as we age, and whether these changes affect our ability to exercise, and whether these changes predispose us, women and men, to the development of disease. So next slide. So as it turns out, what happens to our heart pump depends on both age and sex. And this is just one of a series of analysis that's been performed from my laboratory. So what my lab's done in the past is analyzed or studied a group of healthy older volunteers that were split equally between men and women. And this is a slide from our work which shows wedge pressure. That was the filling pressure that I talked about. It shows us the heart filling pressures in men and women. And the upper left slide shows you that the absolute changes in pressure are not different from between men and women. However, in women, when you adjust that increase in pressure, and that's what the other panels show you, for the amount of work being performed, and even when you adjust for body size, for equal amounts of work performed, women do have a higher wedge pressure. Next slide. So it's work from a program like mine or others like mine that have detailed a number of limitations to our cardiovascular response to exercise. So there is an effect of both age in both sexes, but then whether we're male or female really affects the rate of that age-related change. So as we age, fitness can be measured as something called peak VO2, and that definitely declines in both men and women, but it declines a little bit more in women than it does in men. As we age, there are limitations to the peak heart rate we can achieve when we exercise, so-called chronotropic reserve. There are limitations in the ability to recruit pumping function or contractility, and the ventricular chamber itself becomes stiffer, and it limits filling of the heart so that it only occurs at higher pressure. And unfortunately, the rate of this ventricular stiffening is more accelerated in women as we age, leading to a smaller stroke volume relative to body size. And that's what's consistent with the work I just showed you. And what this means is that limitations are evident at lower degrees of work rate in women in comparison to men. Next slide. So the interaction of aging and sex on biology and physiology then likely manifests as sex differences in the onset of disease and the type of diseases that men and women get. So they get very similar diseases, but they may experience them very differently. And as you all know, this slide really does show that there are sex differences in the presentation of cardiovascular disease. Coronary disease, for example, takes off earlier in men. Heart failure takes off later in life, but both heart failure and stroke, for example, may increase at a more accelerated rate in women. So next slide. So the age and sex-specific changes in heart stiffness likely predispose us to heart failure with preserved ejection fraction, right? And that's a cardiovascular disease that's both clearly age-related and demonstrates a predisposition for women and is a growing epidemic. Next slide. So exercise is a useful probe then to elicit these responses more clearly that reflect ventricular stiffness. And what I'm showing in the purple arrow is when we're young, we're able to do a fair amount of exercise intensity without a lot of increase in pressure. But as we age, right, that relationship becomes steeper. It's actually steeper in older women than it is in older men. And at some point, there's probably likely a cross and a threshold that predisposes us to an actual disease state. Next slide. And that's sort of the groundwork for a lot of my research. We've converted a lot of our methodologic expertise in defining those sex-related differences into a diagnostic, right? So we understand what happens in normal, and we understand what happens with aging, and we've converted that to a clinical diagnostic known as the BREATH program. And our goal is to better phenotype exercise intolerance and identify deviations from normal physiology that might explain breathlessness in men and women. And this is the tool that we're studying in this population of patients with pulmonary hypertension. Next slide. And really, my work really illustrates a couple of classic principles of sex-specific study design. So it's important that we study sex-specific epidemiology of disease, because over the lifespan, men and women tend to experience the disease, or their journeys are somewhat different. It's important in any physiology-based research or biomarker testing to determine responses in a sex-specific manner, because aggregate responses can then be misleading, right? And for some measures, we don't see sex differences. Whoops, sorry. But for others, it is important to ensure we have appropriate diagnostic strategies that are specific for men or for women. Last couple of slides, next. So currently, so I didn't talk too much about our own project, as we're in year 3 and we've recruited about 140 of a planned 186. The pandemic has slowed us down. What is important in my sort of work is that we make sure that women are represented proportionally the way they experience the disease. So, and that we are doing, and the study is currently in ongoing follow-up. Next slide. And in terms of knowledge synthesis and translation, we have had the opportunity to write a few review articles. I do discuss this work at meetings like the American College of Sports Medicine meeting. And as I said, one of the major knowledge translation pieces of our normal physiology work has been the design of this exercise hemodynamic diagnostic. And we have converted this, our success with the heart and stroke, into a couple of other broad programmatic grants, including one from the Ontario Research Fund. Next slide. You know, I think that I must say I'm privileged as an investigator in this pandemic in that my children are grown, so I have not had some of the same limitations that some of my younger colleagues have had. Certainly the pandemic has slowed us all down, but I do feel I'm enormously privileged, really, in the setting of all these terrible things that are going on. The next step in my research is to finish the study, and I think that's my last slide, Kristen. I'm not sure if there's another one. Yeah, so the thank you slide. You can't do this kind of work without a great team, and I've got a wonderful team of nurses, fellows, and colleagues. And I'm going to stop there.
Thank you very much, Dr. Mack. I'd like to hand it over now to Dr. Shamy to continue the presentations today.
Great, thank you so much. It's really an honor to be here with all of you. Can you hear me okay?
We can.
Great. Next slide, please. Following up on Dr. Mack, I have to thank the Heart and Stroke Foundation for their support of this work and of my whole research program. So we received in 2018 a National New Investigator Award, as well as the Seed Catalyst Grant for Women's Health, and that's what's funded the work that I'm going to be presenting today. And none of this could be done without a team, and I'd just like to highlight a few specific people. And I'll mention them again through the course of the presentation, but Elena Brezhnekova, who was our stroke fellow at the time that we started this project and is now an attending physician at Shamy, who has been a major part of this work. We've developed collaborations with Virginia Howard in Alabama, Peter Rothwell at Oxford, and a number of important trainees have contributed to the work. Vignan Yogendra Kumar, who's our stroke fellow last year, Rhonda Lunn, who's a resident and master student, and Ainsley Mathewson and Hannah Ferris, who are medical students. Next slide, please. So just to give you a sense of how I came to ask the questions that we did, so my work is really interested in the interaction between what we know and what we should do in clinical medicine. And this is what we call epistemology, is the study of what we know, and ethics is the study of what we should do. And a core question that exemplifies the kind of work that we do is, when should a randomized trial be done for a given question? I'm not sure how familiar everybody is with the lingo here, but a randomized trial is a kind of a clinical study in which patients with a certain condition are by chance assigned to receive one treatment or the other, so that we can best figure out which one of those treatments is superior in one way or another. Now, randomized trials are very important, and they've been the backbone of developing effective therapies for the last, well, really 30 years, but they're ethically complex. For example, if we already know which treatment is best, then randomizing a patient to receive an inferior treatment would be unethical. The problem that really interests me is, how do we know whether one treatment is more effective than another? And you'd think that this would be relatively straightforward, but it really isn't. It's a problem of establishing or documenting uncertainty. And there are a number of different approaches out there in the literature that have to do with an individual physician's opinion, or some assessment of a group of physicians' opinions, or somehow grounding your decision about ongoing uncertainty in the medical literature. And that's the approach that we favor, which is actually not the most commonly used approach. Next slide, please. So now let's get to the problem of women with carotid stenosis. So carotid stenosis, or narrowing in the arteries of the neck, is a major risk factor for stroke. And about 30 years ago, serious research into this condition led to the conclusion that surgical intervention, either in the form of something called endarterectomy or later stenting, better prevented stroke than did medical management, so medications alone, in patients with recently symptomatic carotid stenosis. And so since the mid-1990s, it has been a standard of care treatment that patients who have had a TIA or a stroke and are found to have narrowing of the carotid artery that was felt to be the cause of that TIA or stroke should have that artery opened up, either by endarterectomy or stenting. Two interesting observations that came out of that early literature is the fact that, first of all, women may benefit less than men from these kinds of interventions. This was suggested in only one of the kind of landmark studies, but also that women were grossly underrepresented in these trials. So as Dr. Mack alluded to, women are more likely to have stroke than men, that as we age, women become more at risk of stroke. And yet these studies recruited, say, 25, 30, 35% of their population were women, whereas it really should have been, at least 50, 55, 60%. And so as a consequence of these two observations, modern researchers are calling to repeat these landmark studies that established the benefits of endarterectomy and stenting, but this time only enrolling women. And so our question, this was the question that was the core of our grant, is would redoing these trials in 2020, 2021 be ethical or not? Next slide, please. So we came at this problem from a number of perspectives. The first was to ask, do we really know enough about how women fare with these various interventions in order to justify doing another trial? So we felt that the answer would depend upon the results of a systematic review, which is the most objective way of characterizing all available knowledge on this question. And of course, none had yet been done, though experts were claiming that we needed new research. And so we conducted a systematic scoping review to answer the question of whether we already had enough data to be able to tell us whether another RCT would be ethically justifiable. So we published the protocol for that review, and then just last week, actually, the results of it were published. And so essentially, published data are insufficient to determine whether women truly benefited less than did men. And therefore, it really is premature to call for repeating these landmark trials. And what would really be required is a patient-level meta-analysis, so really taking all of the patients from all of these different studies that you see in the figure above and analyzing all of their outcomes in the same way in order to be able to answer this question. So Elena Brezhnekova, who you see down below, who's first author on the protocol and last author on the systematic scoping review, is now leading the individual patient data meta-analysis. And so that project is ongoing. Next slide, please. Another big part of this research was the question of whether medical therapy, which is what we would be comparing endarterectomy or stenting against in such a trial, whether medical therapy has really advanced so much compared to what was done 20 or 25 years ago. The problem is we don't know how good modern medical therapy is. And so we don't even know if it's reasonable enough to ask the question, are we comparing apples to apples, or is this really a question of apples to oranges? And so with the help of Vignan Yogendrekumar and now Rhonda Lunn, we're trying to conduct a network meta-analysis where we compare A to B and B to C to then understand A to C. So using published data, can we essentially impute how modern medical therapy would perform for patients with symptomatic high-grade carotid stenosis, and then compare this to what we already know about the benefits from surgical intervention. So this turned out to be very methodologically complex and is ongoing. Rhonda is going to be leading that as part of her graduate work. Next slide, please. We also wanted to take a broader look at the question of conducting a randomized trial in which we only enroll women for a condition that affects both men and women. And so this seemed to us to be a very interesting proposition, but also an ethically fraught one, because we want to ensure that we're not taking advantage of those women who are enrolled in the research and are not just conducting research for the sake of research. And so Ainsley Mathewson, who's an undergraduate student and who, as of last week, we found out just got into medical school, has been instrumental in doing a systematic scoping review in which we look to see how often are women-only randomized trials done for conditions that affect both women and men? And do these trials offer some form of justification for why they have picked to do their research in only women patients? And if so, what are those reasons? And so this also turned out to be methodologically quite complex, and we're in the process of screening essentially 5,000 abstracts to get to the bottom of this question. Next slide, please. This work has actually led us to think more broadly about the way that women's health intersects with these questions of ethics and epistemology. As I alluded to, research into women's health is obviously essential, but are women being taken advantage of for the purposes of conducting research? And how do we guard against this? Is the fact that there is now so much more funding available to account for decades of a gap in attention to women's health, is that actually somehow being twisted in the wrong direction? If there are indeed perceived differences in outcomes for women and men in, for example, in the setting of carotid stenosis, are these real or artifactual? Are they due to biological or cultural or experiential factors? And we've encountered a similar problem when dealing with the question of women with transient ischemic attack and how they are diagnosed and treated differently than men. And so Sophia Gokan, who's a nurse specialist in the stroke prevention clinic, and Tess Fitzpatrick, who is a stroke neurologist who was a resident with us and now is working in Toronto, have guided a series of projects that we've been looking at in this area. We're also very aware of the fact that women have been underrepresented in stroke trials for decades, and we've been asking the question of how we might address this. And one of the potential approaches is to use something called advanced consent. So essentially to ask women who are at risk of stroke or TIA to consent when they're in a clinic setting that they might be enrolled in acute stroke trials when they do present in the emergency department in extremis, aphasic, unable to provide their own consent. The reason that this is particularly important for women is that, as we know, women are more likely to have their strokes when they are older, when they are, for example, widowed or living alone, and when they do not have a substitute decision maker available to consent on their behalf. Next slide, please. Once again, thank you for your attention this afternoon. Thank you to Heart and Stroke for their support. Thank you to my team, to my family, and to all the healthcare workers keeping us safe in the middle of these very difficult times. Thank you.
Thank you very much, Dr. Shamy. That was an excellent presentation. And I'd like to remind our attendees to post any questions in the Q&A box, and also to pass it over to Dr. Margie Davenport.
Thank you so much. I'm really honored to be here today to have the opportunity to tell you a little bit about the work that I've been doing over the last 4 years and how the Heart and Stroke Foundation of Canada has been absolutely critical to the success of my research program. Next slide, please. So I lead the program for pregnancy and postpartum health at the University of Alberta. And the overarching aim of this program is to improve cardiovascular health during and following pregnancy in both mothers and in babies. And in 2017, I was awarded a National New Investigator Award in Women's Brain and Heart Health. Now, as an early career researcher, this award played an absolutely pivotal role in launching my research program by protecting 75% of my time for research for a 4-year period. Next slide. Now, we know that pregnancy unmasks future chronic disease risk. And in fact, the evidence is so strong now that in 2011, the American Heart Association listed pregnancy complications, including gestational diabetes and preeclampsia, which is high blood pressure during pregnancy, as risk factors as strong as smoking for the future development of cardiovascular disease. If you aren't already aware, pregnancy is associated with some pretty profound physiological adaptations in order to support the growing fetus. And while the vast majority of pregnant women are able to accommodate the cardiovascular demands of pregnancy without consequence, which you can see in the blue dashed lines along the bottom, pregnancy can actually unmask individuals who have previously undiagnosed underlying cardiovascular disease risk, as you can see in red here. So in these women, the normal physiological adaptations of pregnancy may actually cross the threshold for vascular or metabolic disease during pregnancy, resulting in a diagnosis of either gestational diabetes, gestational hypertension, or preeclampsia, among other conditions. And so these pregnancy complications can lead to the future development of overt cardiovascular disease much earlier in life than we would see typically otherwise. Next slide. So thanks to the support of my Heart and Stroke New Investigator Award, I was able to focus my protected research time on a variety of projects. We looked at blood pressure control in women who had preeclampsia. That was led by Dr. Laura Reyes. We were looking at the effects of pregnancy and exercise on cardiovascular health, including in the babies, by Dr. Vicky Mia. We had an interventional trial looking at why exercise might be cardioprotective during pregnancy, led by the soon-to-be Dr. Rachel Scout. But I'd like to just highlight one project that I completed during the tenure of my award, and this was the development of the 2019 Canadian Guideline for Physical Activity throughout pregnancy. Next slide, please. So this was this new guideline really was the culmination of a 3-year process by a pan-Canadian panel of clinicians, researchers, and policymakers, as well as we had lots of feedback from pregnant and postpartum women throughout the entire process. And the goal was to develop evidence-based recommendations for exercise during pregnancy. So I had the great pleasure of being the chair of the Guideline Consensus Panel. And as a panel, we developed 12 systematic reviews, which provided the evidence upon which this new guideline was developed. So we had 12 systematic reviews. They looked at everything from the impact of exercise on maternal health. So were women more likely to develop gestational diabetes or preeclampsia? What was the impact on the baby? Was the baby born large or small? Was the baby born earlier, etc.? And based on our extensive review of the literature, we were able to develop really strong recommendations that women who are pregnant engage in at least 150 minutes of physical activity spread over 3 or more days of the week, right from conception right up until delivery. So 150 minutes sounds like a lot, whether you're pregnant or not, and this can be broken into either 30 minutes, 5 days a week, or just go for a 10-minute walk after lunch and dinner every day. But this recommendation in terms of cardiovascular health, one of our largest findings that we had from our research was that we found that women who engaged in physical activity during pregnancy had a 38% reduction in the risk of developing gestational diabetes and a 41% reduction in the risk of developing preeclampsia and gestational hypertension. And this was without having an increased risk of having a miscarriage, small baby, or preterm delivery, which are common reasons why we're told that women don't exercise during pregnancy. Now, the outstanding question that we do have is that if exercise during pregnancy can reduce the risk of developing these complications, we may also be able to prevent or delay the long-term development of cardiovascular disease in these higher risk women as well. Next slide. So since the release of the guideline, we've been really quite honored and thrilled that Hypertension Canada just listed prenatal exercise based on our work as a preventative tool to reduce the risk of having high blood pressure during pregnancy. And this is a therapy that's available to both low and high risk women. These guidelines have been recently incorporated in the World Health Organization physical activity and sedentary behavior guidelines, and they included a section on pregnant women, which was based on our work, as well as a variety of other global groups. Over the last couple of years, my team's really been trying to disseminate more information about exercise during pregnancy. So we've developed a number of different infographics, short videos, social media platforms to be able to help spread the word across Canada and beyond. And one of the recent pieces that we've been working on in conjunction with the Canadian Society for Exercise Physiology is a questionnaire that's getting released next week. It's the Get Active questionnaire for pregnancy, and it's designed to help reduce barriers to physical activity in pregnant women. Next slide, please. So certainly COVID has presented many challenges. You know, we're all very severely impacted. Our research programs have certainly changed and adapted. I like to focus on the positives as much as possible. And so although there's been lots of negatives, I would say that one of the key silver linings of the pandemic is that my travel has actually reduced significantly. It's meant that I've had a lot more time to be able to spend with my family and my two little girls who are growing much too quickly. In terms of my research, certainly most of our in-person cardiovascular assessments have been slowed or stopped. But I work with some really incredible, energetic, and very smart trainees. And so together we've been able to find new ways to be able to conduct our research virtually. And they're very effective. We continue to be able to conduct research that I strongly believe will continue to impact the cardiovascular health of pregnant women and their children. And we'll continue to do some of that or incorporate that into our research program even post-pandemic. I can't emphasize it enough. The work we do is really the work of our trainees, and none of this would be possible without them. Although my new investigator award is finishing in the next couple of months, there really is a lot of work left to do in this area. My team is certainly looking at how long the productive effect of exercise might actually last, whether it can potentially improve long-term cardiovascular risk for women over the longer term. We have a number of ongoing studies, some paused, some restarting, looking at the underlying physiological mechanisms of why exercise is beneficial. And this fall, I'll be starting the process to develop new postpartum exercise guidelines. And so, of course, there's lots of exciting work ahead, but looking back over the last 4 years, I think it's very clear to me that none of this would have been possible without the support of the Heart and Stroke Foundation. So a big thank you to them for their forward thinking and really important initiative that I have very much benefited from. So thank you very much.
Thank you, Dr. Davenport. So our last speaker, last but not least for sure, is Dr. Abdel-Qadir. Take it away.
All right, so good afternoon, everyone. I want to begin by thanking the Heart and Stroke Foundation for funding my research. I'm at the beginning of my research career, and as you can see, I'm studying research topics that don't necessarily fit within mainstream cardiovascular research. So there would have been ideas which, although I believe are important and I hopefully will convince you are important, would have been hard to fund otherwise, and this would not have been able to occur without your support. So thank you. Next slide, please. I'm going to focus on my research study, which is funded through 2 awards from the Heart and Stroke Foundation of Canada. So I'm in my 3rd year of an early career Women's Heart and Brain Health Research Chair, an operating chair. And I was fortunate enough in the past summer to receive a National New Investigator Award and a Seed Catalyst grant from the Heart and Stroke Foundation. Next slide, please. So this figure sort of illustrates the main ideas I'm trying to study as a cardiologist. So a big focus on my research is cardiovascular health in patients with cancer, with a particular focus on women being treated for breast cancer. And this is because most of the best treatments for breast cancer, unfortunately, have negative impacts on heart and brain health. And this traditional simplistic thinking around it has been the idea that cancer treatments are designed to be controlled poisons that are meant to kill cancer cells, but because cells of the heart, brain, and the endovascular system are very metabolically active and share similar pathways to active cancer cells, are damaged and killed by these cancer drugs too. However, we're increasingly learning that the relationship is not as simple as what this figure may indicate. And can you please move on to the next slide? And we're increasingly recognizing that the relationship is more than just a drug and toxicity effect. There are a lot of data, emerging data, which suggests that ethnic minorities and women with lower socioeconomic status are at much higher risk of developing the adverse cardiovascular effects of cancer treatment, including higher risks of developing cardiotoxicity, metabolic syndrome, and cognitive dysfunction, which is colloquially referred to as chemo brain. And so the hypothesis that I'm looking to unpack in this research program is the idea that these are mediated through social, cultural, and environmental factors, including income, education, social support, the cultural environment, and gender roles, which may predispose women to higher or lower levels of stress, anxiety, and worse mental health after a diagnosis of breast cancer, which can then interact with the direct cardiotoxic effects of the cancer treatment to provoke the worse heart and brain health that we see in cancer survivors. And in particular, the phenomenon of chemo brain, in addition to the biologic predisposition to it, may be much more likely to emerge, but also much more likely to be debilitating in women who have environments that put them, that make it harder for them to deal with its effects. So you please move on to the next slide. So to address these ideas, we designed the study that we affectionately refer to as Champion. So this is a pilot prospective observational cohort study that's been funded by the Heart and Stroke Chair. And our target is to recruit about 300 women from 6 centers in Ontario, and to try and really well characterize their journey, their cardiovascular and mental health as they go through their cancer diagnosis and treatment journey. We kept our inclusion and exclusion criteria quite broad. So we're looking to diagnose women with early stage breast cancer who are at higher risk for cardiovascular disease based on their age and being treated with chemotherapies that we know have a higher tendency to harm the heart, anthracyclines and or trastuzumab, which is also known as Herceptin. And we're excluding women who've had prior cancer, atrial fibrillation, or heart failure, women who may be unable to adhere to the study, and women with life expectancies of less than 5 years. Now, one thing that isn't formally listed as a criterion, but an overlying principle that we are trying to take account in designing the study is to try and make sure that we capture the whole spectrum of socioeconomic status, because we do know studies such as these, and particularly studies in breast cancer, have tended to preferentially recruit women who are more educated and who come from higher socioeconomic status, because for you to be able to take on a research study on top of the extremely stressful journey of being a cancer patient going through chemotherapy, will self-select for patients that are handling things in a better manner. Next slide, please. So in terms of the big picture, this is part of a larger research program that's trying to advance several principles that I have come to through a combination of my research using administrative data at ICS, where we follow the long-term prognosis of women with breast cancer, research that is done at other centers, but also in speaking to my patients and trying to get seeing them in clinic and trying to understand what is really important to them. So the data that we and others have generated in terms of long-term prognosis, comparing cardiovascular risk versus cancer recurrence risk in women with breast cancer, indicates that even though these drugs can be really toxic to the cardiovascular system, that most women with breast cancer and even women with early stage breast cancer are best served by receiving the best cancer treatment possible. So even though we're worried about their cardiovascular health, it would be very rare that we would recommend that someone get a less effective cancer treatment because we're worried about the heart. And rather, our focus needs to shift from the current focus on the cardio-oncology research, which is trying to look for increasingly more sensitive ways of trying to detect cardiac injury. So our research program is trying to move away from that. And rather than trying to pick very subtle markers of cardiac injury, which may or may not matter, we try to move towards earlier detection of women who are on their way towards developing cardiovascular disease that is going to be clinically relevant. And if you speak to our patients, they tell you that they really do not want to compromise their cancer treatment unless they're going to develop heart disease that is important enough that's going to cause symptoms and impact their quality of life, or obviously if it's going to limit their length of life. And, we want to move the conversation away from trying to avoid the cancer treatment, which they need to reduce the likelihood of their breast cancer coming back, towards trying to avoid further insults to the cardiovascular system, which are things that we can control. So controlling things like hypertension, diabetes, dyslipidemia, and stress. And when we speak to our patients, although we as cardiologists, our first instinct is to reach to our prescription pad and write a prescription for an antihypertensive or a statin, they really tell you that as much as possible, they would prefer to address this through lifestyle or risk factor modification, rather than getting more medications at a time when they're already getting a lot of medications at a time of chemotherapy. But doing this really requires us to consider their mental and emotional state. As you can imagine, this is an extremely stressful time for our patients. The diagnosis of cancer, uncertainty about their long-term prognosis, and then dealing with the difficulties that come from chemotherapy. So if we are going to develop these approaches, it really requires us to develop a good understanding of what their mental and emotional well-being is like through their cancer treatment. And then finally, the big picture that we're trying to encompass in our cardio-oncology research, including in Champion, is that cancer treatment with cardiotoxic chemotherapy is one of the rare settings where we know that a human being is going to get something that is going to harm their heart. We know when they're going to get it, we know what dose they're going to get it at, and they're going to be in a setting where we're going to be following these people very closely. And, so, the chemotherapy is a necessary evil from a cardiovascular perspective, but it does allow us a chance to understand, to learn lessons that we may apply towards people's cardiovascular health in general. So we're trying to use Champion to try and understand biomarkers and other prognostic factors that can help us learn lessons that we can then apply in the future to perhaps someone who may have had a heart attack, or someone who may have high blood pressure, or someone who may have someone who has diabetes. How can we find out who are the people who are going to end up with heart failure and who are the people that are probably going to end up okay? And then the other opportunity that we get to study here is the relationship between stress and mental health and cardiovascular illness. Because we do know that there definitely is a link between worse mental health and higher levels of stress and cardiovascular health. But in most cases, the source of stress has been present throughout someone's life and is continuous. Cancer is a setting where we know exactly when this source of stress begins. And hopefully, as women clear their cancer, the source of stress goes away. So perhaps this may allow us a chance to learn about the relationship between mental health and stress and cardiovascular disease in a manner that is easier than other disease states. So next slide, please. And this is particularly relevant for women because there are a lot of data that suggests that the negative impact of negative mental health and stress appear to be worse in women than men. But this is not necessarily an indicator that women are intrinsically less able to deal with their stress, or the cardiovascular system is biologically more predisposed towards negative impacts from stress. Please move on to the next slide. Rather, this probably is more for representation of the environment, and this is an environment that predisposes towards where women may have less ability to manage the sources of stress. This is supported by studies such as this. This is a study that was led by Drs. Pelletier and Pilote, who looked at young patients that had a heart attack and looked at predictors of bad outcomes after a heart attack. And they showed that it is not necessarily biologic sex, but gender that is a stronger predictor of worse outcomes. So whether you're a man or a woman, if you fulfilled roles that were more traditionally associated with feminine gender traits, those people were more likely to go on to have adverse health outcomes, probably related to the fact that they were more likely to have high levels of stress unless able to control their life. Next slide, please. So in terms of progress, we, unlike a lot of people, we really were held back a lot by COVID. for two main reasons. One is the fact that our patients, those with heart disease and cancer, are at a really high risk for adverse outcomes. So we obviously felt that it was unethical to provide them with unnecessary exposures, but also because measures of stress, anxiety, and lifestyle were some of the key things that we wanted to study. And we were concerned that our measures may not be valid outside of the setting of COVID. So we had to go back to the drawing board and redesign our whole study, including redesigning our data collection approaches to try and do things virtually as much as possible. And we're now looking to recruit our first patient if and when this third wave ends. Next slide, please. So in the meanwhile, the seed catalyst has allowed me to pursue other work that is related to these ideas. So we are doing a systematic review focusing on inequities in cardiovascular care and rates of cardiotoxicity after breast cancer chemotherapy, which we're going to hopefully complete towards the end of the summer. Now, the other area where I spent a lot of time thinking about are sex and stroke risk and atrial fibrillation, because one of the pathways I'm going to be looking to study is whether cardiovascular abnormalities, including occult atrial fibrillation, may predispose towards cognitive dysfunction, the chemo brain that a lot of our patients suffer from. And it's got me spending a lot of time reading and thinking about sex and stroke risk and atrial fibrillation. And traditionally, female sex has been considered a risk factor for stroke, meaning that being a woman means that you're at higher risk of stroke if you have atrial fibrillation. But a lot of recent data seems to suggest that female sex is not a risk factor per se, but a risk modifier. So what this means is if you have atrial fibrillation and you do not have other risk factors for stroke, being a man or a woman does not make a difference. However, if you have atrial fibrillation and you have an additional risk factor for stroke, whether it's older age, hypertension, or diabetes, women do worse than men. And my hypothesis is that this is probably not a biologic vulnerability, but rather this probably represents undertreatment of these risk factors for stroke, especially amongst elder women. So we know that rates of using blood thinners are similar between men and women, but trying to treat other things like blood pressure, diabetes, and cholesterol, I suspect happens less well in men than women. So we're going to be looking to use administrative data sets in Ontario to try and study this systematically. And if it turns out that I am wrong and that women are indeed independently at higher risk of adverse outcomes from these risk factors, then it suggests that we need to develop separate risk scores for stroke in men versus women with atrial fibrillation. Next slide. So in terms of knowledge translation, I'm relatively early in my research program, so I haven't had the chance to present data yet. The design of the study was involved in collaboration with people in cardio-oncology across multiple sites. After designing the study, we've presented the principles underlying it to the sites that are going to be helping us recruit patients in the Canadian cardio-oncology networks. And like I said, this work has involved continuous ongoing conversations with the patients that I see in my cardio-oncology clinics. Next slide. Okay, and then finally, I really wanted to reiterate my gratitude to the Heart and Stroke for allowing this line of research. Like I said, I don't think it would have been possible without your support. So thank you very much.
Thank you very much, Dr. Abdel-Qadir. I would like to open the floor for any questions and ask all our speakers to join us again. I know we're almost at the end of the webinar, but I think we may have time for at least one more question. So for all our speakers, and I know Dr. Abdel-Qadir, you've already alluded to this in your presentation, but I think looking forward and particularly with existing inequities that have been amplified by COVID, how do you see your work evolving beyond sex and gender to potentially examine the intersection with other social, cultural, and socioeconomic disparities and other systems of power per se, also racism and discrimination, etc. Perhaps we'll start first with Dr. Mack, and then Dr. Shany, and then Dr. Davenport.
Yeah, it's interesting that you. I'll just go on a quick tangent. So a lot of I've recently been asked to join a group to look at mechanisms of COVID long in patients and the ongoing breathlessness. with the CAN COVID project. And what we noticed there in looking at that particular database is how the population who have really been hit hardest are, so I know my camera's not on. I guess I should, I myself am a daughter of Asian immigrants. It's not like you guys can see that. But the population in long COVID clinics is not actually representative of some of the Black and Brown people who have actually been affected the most by the pandemic, at least in urban Toronto. You know, I think it's, so no, I don't have a perfect answer for you. I just know that it's something that we really, as much attention as we've now paid and as grateful as I've been to the women's, to this particular network, actually taking some of the principles we've learned there to turn our attention to exactly what you raised, I think are vitally important. And that's all I'll say on that. But it's an excellent, excellent point.
Shamy?
Oops, sorry. Rather than unmuting myself, I unvideoed myself. So one of the, you know, our interest in the ethics of clinical trials has been very relevant to COVID, what with all of the trials that have gone on related to hydroxychloroquine and vaccines, et cetera. And so there are more examples of these fundamental questions of when do we really need to do more research. From a COVID affecting women's cerebrovascular health angle, there is certainly now, with limitations to access to preventative measures, a concern that women and those groups who are already receiving less preventative care might be further disadvantaged by the fact that everything is being squeezed. And from a participation and consent for clinical trials point of view, I think the model of advanced consent that we're exploring is even more relevant now, because essentially no patient will have substitute decision makers present with them in the emergency department at the time that they're being asked to participate in clinical trials, because nobody has their family with them.
Thank you, Dr. Davenport. Would you like to add anything?
I don't think I have a lot to add. You know, I think that there's still quite a lot of work that we all need to be doing. Heart and Stroke has really done a fabulous job at helping to raise awareness of the importance of sex and gender in our research. And I think that's all I have to say.
Thank you. Dr. Abdel-Qadir, I know you've alluded to this in your work and how you're incorporating some of these aspects. I wonder if there's anything that you would like to add, or to perhaps a recommendation for other scholars out there who may be interested in also conducting this work and going beyond sex and gender factors.
Yeah, I mean, I would emphasize the fact that it clearly is an important point. You know, and I think we have, and you know, and I do think I would like to see over the next 20 years we try and make this, you know, similar strides with trying to study inequities in health care and outcome based on race and ethnicity, and learn lessons from what has been done in terms of trying to improve sex-based disparities. We're nowhere near perfect in terms of reducing sex-based disparities, but we have made a lot of progress. And I do hope that we can use some of these same principles to improve inequities in other areas.
Thank you so much. I have a very particular interest in this area also, as my research should be looking at the intersection of sex, gender, and other factors too. So I'd like to thank you all for attending our webinar today, and thank our speakers for their excellent presentations and showcasing their research programs and the ways in which they are advancing heart and brain research. The Heart and Stroke Foundation will be hosting other webinars, so I want to encourage everyone to join these. So thank you all, and hope you have a great day and stay safe.
All right.